All right. All right. Welcome, everybody. Wow, we already have a crazy number of people coming in. Fantastic. Welcome, everybody. Glad you decided to join us. Who do we got? We got Aisha, we have Carol, Kelvin, Vicky, Sue Ann. Love it. People coming in over 100 so far in already. Rob Coffee.
Howdy, folks.
Awesome. Make sure I can make this work for us when we're ready. All right. So the question of the day. First of all, where are you from? Where are you from? Not necessarily your organization. Where are you from in the United States? Number one. And number two, who is your favorite musical artist or performer? All right. So what do you got there, Rob? Who's your favorite? And you put it in the chat. Pop that in the chat, everybody.
I'm gonna go.
How to do this?
I'm gonna go Stevie Ray Vaughan.
Atlanta and John Prine. Holy cow, Teresa, digging out some John Prine. That's fantastic. Santana, love it. What's yours?
Stevie Ray Vaughan.
Stevie Ray Vaughan. Yeah. Lewis from Maryland and Pink, Boston. The VA, is that a singing group, or are you just from the VA? All right, who we like? Earth, Wind, and Fire from Atlanta, from Terry. PA and Queen, Nanette, nice. What's your favorite Queen song, Nanette? That'll be a winner. Richmond, Mary Beth is you too. Texas, Rob Thomas. I love Rob Thomas, Robert. That's awesome. Robert Blanford, nice. There it is. Robert, you got yours in there. Knoxville. Caryville, Journey from Dora. Love it. Freddie Mercury from Mariana. Love it. Michael Jackson. All right. That's about as much you're going to get out of that.
Do that again.
Peggy, Julia Roberts. All right. I didn't know. That's okay. Pat Benatar. Love it. Ellen. Chicago. Are you from Chicago, Nana? Is that N-N-E-N-N-A? Very cool, by the way. Nena. Is that, I'm hoping I'm doing that right. She said Chicago. Creed. Love it. With Natalie. George Strait, Alicia. Nice. Elvis Costello from Piper. Nice. Then we have Ashley says, Rihanna, we know which different generations those are now, don't we, Rob Coffee? Lady Gaga's another newer one from Tisa. Adele, like Janice. All right. Bob Marley. Love it. Atlanta. All right. Another Queen. And Linda, her favorite artist is VHA. I'm sorry. I couldn't resist that, Linda, from Northern California. All right. And so the question is, where are you from and who's your favorite artist? And I have mine right here. And that would be The Boss.
Nice.
Bruce Springsteen. And if you've ever seen Springsteen, he'll ruin concerts for everybody else that you ever see. Just saying. So nobody else has got that. All right, too many to name. All right, AC/DC, Boys to Men, Led Zeppelin, Fleetwood Mac, Michael Jackson again. And I'm not going to do two Michael Jacksons. That almost deserves it. Just saying, I could do it again, Rob. I'm not going to do it again.
Please don't.
All right, too many to list. Terry with a good. Terry says that was a good attempt from me and my Michael Jackson. Okay, but Rob says I can't do it anymore. Oh. All right, Van Halen, Paul, nice. Lots of great artists. Greta Van Fleet, okay. Korn, Stevie Nicks. All right, we got it. Oh yeah, Bruce, love it, Deborah. Prince, we got Prince from Sunny. I was waiting for that one. John Denver, love it. BB King, okay. We got to do some business here. We can't be talking about music all day long. But welcome everybody to the virtual telehealth patient care monitoring and best practices. We have a criminally large number of people coming to this. Robert. I know that there's a bunch of folks that are asking questions about, they'll be asking questions about whether or not it's being recorded. Yes. Will you get the presentation? Yes. Will you get all the rest of the stuff? Yes, you will get all those things. And we'll make sure we get that. We want to welcome everybody that's here. We got a bunch of folks from the VA. I know that there's a bunch of people that thought that I was asking who they were with, but it was actually your favorite musician or performer. But there you go. But we got a bunch of folks from the VA. A lot of people are asking questions that they want answers to. So we'll get to those. Promise you. We also got folks from Border Protection, Indian Health, the Army, CMS, a bunch of folks from CMS actually, HRSA, and the Air Force. So we just want to welcome you guys. We love what you do for helping out people.
Absolutely.
We asked this on coming in, Rob Coffee. The best briefing ever from Raquel. My computer cooperates. I can't help you with that, Raquel. Dorothy, it discusses how not to waste the provider's time in teaching patients on how to log on to their appointments. Tiresome and laws of care. Gotta love that one, right?
Yep.
Tammy from the VA, if it's interesting enough to keep my attention. So there it is, Rob. If we're now not paying attention, I'm busting out the Michael Jackson.
I'm just going to say, then you can go back to Michael Jackson.
I go back to Michael Jackson, right? Topics are easily understood, already tested from Margot. I believe that we're going to talk about some of that today, right, Rob?
Yes, sir.
All right, Cipriana. We can gather best practices to share with other recipients and stakeholders. Always love that, Cipriana. Kathleen, demonstration of veterans healthcare addressing combat-related issues and validated outcomes of improvement. I don't know if we're going to dive in that quite deep, but Kathleen, but I'm certain that you will see some things that are going to be beneficial because of how that works with telehealth. I think that it will be part of that, sort of. Michelle, examples are provided that illustrate how remote patient monitoring devices minimize health effects. Love that. We'll give you some examples of that, won't we, Rob?
Yes, sir.
Yep. Mary Beth, I can improve my practice performing RPM assessments. Always love that. Patricia, you address how to handle medical and behavioral health emergencies that are occurring during telehealth encounter. Absolutely talking about that. Right, Rob?
Yep.
And there are applicable ideas to incorporate into practice right now, she says, and says right this minute. Sharon, we can apply the knowledge acquired immediately. Two of them, Ann and Sharon, both. You're going to apply that? Hopefully we can. Cinnamon, it's entertaining. Uh-oh, it's on, Rob. It's on. We have to be entertaining. Robin, I received practical takeaways will help us improve our program, hopefully. Roderick, info in chronic disease and RPM addressed. Absolutely. That's part of what we're going to talk about, right, Rob? Is how some of this is temporary and some of this is, ongoing, right?
For sure.
Mary, can we move our surgery prep center towards telehealth connect model? Wow, that's a good one. I hadn't heard about that one yet. I'll bet you by golly, just a little bit of creative thinking that can happen, can it, Rob? Dean, information is distributed succinctly and you stick to the time schedule. Okay, well, man, I already messed that up with my first question. All right, Sheila, please address these. There's been meaningful improvement in virtual care impacting outcomes for rural. That's a big deal, right? And
absolutely.
And VS industrial, love that. Areas of care, love it. I think you're right, Sheila. And it has, and it's going to continue to improve, but there are bumps in the road that we'll talk about. Amy, health outcomes related to face-to-face care versus telehealth. Love it. Veronica, how the virtual telehealth workers monitored to make sure they are taking care of our veterans. Veronica, let me just say this. For all the folks that are here from the VA, thank you for what you do, because that's exactly the model. Everybody I've ever talked to from the VA, they're hardwired to make sure that everything that's happening is taking care of the veterans, and we thank you for what you do. Rebecca, how can we get upper management to buy into the value of remote patient monitoring programs? Let them take a look at what we're going to talk about today. Carolyn, how do you address technical issues outside the area of CONUS? I won't read all those. Chris from HHS-CMS, CommonMD's revenue model. They want to know how you're making money, Rob. And any safeguards it feels are integral to a vendor that provides a service paid for by the public. We'll absolutely talk about that. I'm not going to get too much into the revenue model per se, but I think you guys can talk about that as it applies to CMS for certain. Benita, effective educating of the elderly who are resistant to technology. Wow, if that doesn't fit right into the presentation, huh, Rob?
Indeed.
Carol, evaluation of worsening physical disabilities. Love that. That's always a part of what can be addressed. Anita, how long we anticipate being able to provide virtual care for the veterans? We can answer that right now. Rob, how long do you think that's going to be?
I don't think it's gonna end.
It ain't gonna stop.
It's gonna get improved. We'll talk about that too.
That's right. How to get patients on board with virtual healthcare. Many are reluctant to use. Absolutely. So you got to make it easy for them. Otherwise, they're not going to do it. Right, Rob?
Mhm.
Brenda, I understand how telehealth can take the place of face-to-face assessments and whether medications are working. Love that. We're going to talk exactly about that, Brenda. Emily, there's any evidence for telehealth being non-inferior to in-person care in primary care settings? Love that too. That means, is it really working as opposed to being in person? Love it. Marcia, marketing, education, leadership support for RPM and telehealth. I love it. And Rebecca, medical oversight for in-home telehealth. That's the second one we look for that. And how to integrate into community practice for Robert. Wow, there's a bunch of stuff there. We will do our best to answer all those. If not, I promise you that Rob will be glad to talk with you anytime that you would like, and you continue the conversation. We'll actually provide an access for that. First, before we start this, we need to make sure, because we're GovBrief, and this event is not affiliated or endorsed by GSA or any other agency. GSA makes us say this. And it's provided to you for informational purposes only. And so you can participate. It's not an endorsement or commitment to purchase from any vendor. Everybody got that? We're good to go. So session docs, you'll have the briefing presentation. We're going to pop that into the chat. I promise that's coming shortly. Briefing presentation, presidential executive orders, the NGA telehealth memo, and the VA's national strategy for preventing veteran suicide, which is a very noble effort. If you've been living under a rock in the past couple of years and you don't know where you are in Zoom, you can go up to the top and you can pick this side-by-side mode, and that little thing in the middle enables you to be able to make us bigger, smaller, whatever it is. So participation is good. So for all the docs and all of our regular communication on our favorite artists, and mine is the boss. If you want to pop that into the chat, you can. That's what that's going to be for our docs, getting those to you, as well as what you would like to say. Now, if you have real questions, and I think we will have some real questions, do me a favor, raise your hand up, and we can create some interaction, and then we can also use the Q&A. So if you pop it in the Q&A, we can also just roll right in there and do it. If you have something that's private dialogue that you want to reach out and say, I don't know if I want everybody else to see this, send it to rob.coffee@cometmd.com. And Rob, you're going to do your best to be able to answer all 750 questions that come to you.
I will do my very best to get them all answered in the first 30 seconds.
That's right. All right. So with that, why in the world did you decide to join us today? Is it because you're in telehealth management and looking for solutions? I'm a healthcare provider and looking how to use telehealth. I'm in a healthcare administration. A lot of folks need to know about this from the healthcare administration firm. Are you from procurement and want to understand about that? Or my boss made me come. There has to be more than 2 Weisenheimers in this, Matt, and you can choose as many as you want for that. And while we're doing that and we're learning what they are, and a lot of folks that are in administration, and a lot of them are healthcare providers. Love it. Thank you for doing what you do on that, on both sides. All right. So give us a little dose about Comet MD. I know you're headquartered in Knoxville, Tennessee. What made you get into this space and
Sure.
and give us an overview?
So the company was basically founded out of my previous companies were dealt with in-home senior care, and we were providing great help, watching these seniors, having our caregivers in the home every day, and just started realizing that as much as even their families are trying and everyone's just trying to give them the best care, it just wasn't practical to take them to doctor appointments all the time. And the days of house calls are long gone. So we realized that some of these patients just needed better care than they were getting. Like many of us, they would see a doctor once a year, maybe twice a year. And some of them had relatively chronic issues or just needed a better level of care. And we realized that technology would be a great way to kind of stem that.
So were you cool before COVID? That's the question.
Oh, yeah. Yeah, absolutely. Way before. Comment actually was, and Comment was Comment existed. Our telehealth platform was all put together. I would say we started in with a commercially released, probably 2015, 2017, somewhere in that area. And then but it was only kind of not really commercially released, but it was built for that. And we were just using it with our seniors in our in-home senior care business.
And because of that, you branched out, and you can see all the bullet points here. You actually have healthcare professionals on staff. We're not going to talk a lot about that. But you're a small business, you're out of Knoxville, Tennessee, and you're currently, so folks, listen up. You're currently building relationships with folks that have GSA contracts as well as socioeconomic, because you're small, but you know that doing business with the VA is very important, and you're going to need VA partners. So if anybody from the VA, especially in procurement, there's a few from procurement, but even if not, if you know any of the small businesses that Rob needs to meet, please, please, please give him an introduction to those folks and say, hey, this is something that you need to take a look at. And for those of you that are 200, we got 205 responses so far. So I'm going to give you another 5 seconds for the rest of 80 people that are here. 5, 4, 3, 2, 1, and boom. So here we are. I'm going to share this out. We have 23% are in telehealth management, and we have 45% that are healthcare providers. That's awesome. And then 31% are administration, a few from procurement, and I love the Weisenheimers because they're the ones. They're the ones that really make the world move, right? The ones. There you go. Love it. So one of the main reasons we're here is because we have multiple presidential actions that have come down with executive orders, other memoranda that are flowing through, right? And it's real important for folks to understand the why, right, Rob? So sometimes it just happens, right? And we have to do this, but they don't say why. So improving the healthcare includes, and this is called out for telehealth services, especially as applies for Medicare beneficiaries. Big deal, right, Rob?
Yeah, absolutely. Huge deal.
It's a huge deal. And improving rural health access. My in-laws live in the middle. I'm talking, you have to drive from the middle of nowhere to get to Burkesville, Kentucky. If you know where Burkesville, Kentucky is, let me know. It's South Central. And literally they have to drive for an hour and a half to get to a doctor's visit. And they need this. They don't even know about it yet, but after this, they're going to know about it. They need this because they have to have the communication to the docs. They really need it bad. And make permanent the policies. There was a question about how long this is going to last. I don't think it's going away. Making permanent the policies to improve the accessibility through telehealth. So there you go. And the other part that really weaves into this is empowering the veterans and suicide. That's actually called out as well. We'll talk about that. And the memorandum for long-term effects of COVID-19. Rob, we don't want to have people sitting in hospitals for 3 months if they're just in recovery, and you have to monitor them closely, right?
100%.
They're much more comfortable at home, right? So other governmental actions, I'm not going to read all this stuff, but this, what's that?
I said, and it keeps the healthcare costs lower, keeping them
absolutely. Home. Absolutely. So this is from the National Governors Association, and this just shows you that it's come through the federal side, down in through the states, a lot of adoption to make this work. We had laws that didn't allow for it, and we had those had to be reworked quickly in order for us to be able to handle COVID, right? So we have the VA doing great things. In fact, talking about the national strategy for preventing veteran suicide, it calls out broadening the telehealth services, because guess what? We want to monitor physiological conditions, right, Rob?
Absolutely.
And that way we can find out if they're on their meds and be able to react and connect them with people that can truly help. And we applaud everything that the VA does, but that one is a particularly
kind of a hot button issue for all of us here too.
Hot button, super important thing, right? And then we have other agencies like the FCC. Imagine that. Other agencies coming in. FCC announces new COVID-19 telehealth program that's back in 2021, September 2021, right? So that's not that long ago. And here we go. We see $41.1 million, right? Almost $1 million going to Covenant Health in Knoxville and also Cherokee Health in Talbot, both of those in Tennessee. I think we pulled these up because you happen to know a little bit about those, don't you?
Correct.
That's right. So before we jump into the next part, and we'll get to your questions in just one second, what is your experience with telehealth? And this is a two-part question. So you do RPM, remote patient monitoring, if I could speak, virtual visits with specific medical specialty. You can choose as many as you want. And then how did it go? Let us know how it went, because this is where we really start the good dialogue. And as I mentioned before, you can participate. If you want questions answered, I can't see them in the chat because there's like a billion chats in there. So raise your hand if you'd like to communicate. All right. So I'm certain that VHA Mary D. Too many. That's probably in response to how many which are artists. Renee says, will you please send this out for individuals who are not able to attend at this time? You better believe it, Renee. In fact, we're going to do a recap, which will have all the documentation, including the Q&As in there for everybody. So that's a great point. And anybody, no other questions? There's no way that could be named. That's all. All right. So awesome. Let's take a look at what we have here. And you got another 5, 4, 3, 2. We'll give, there's a couple of, it's still coming in. Let's give him another 10 seconds you got. And then we're going to talk about this. Can you see the results there, Rob?
Yes, I can.
As they're coming in?
Yep.
So 46% are remote patient monitoring, 62% we're using it for virtual visits, because there's a difference there. And we're going to talk about those. And then specialties, pilot within a facility, love it. And look at the bottom part. Most of the time, excellent. Sometimes the patients struggle with technology. Yeah, that happens, doesn't it?
Big time.
And then physicians struggle with the technology. No offense to the physicians. Back end, all right. So another 3, 2, 1, and that's it. So there you go. Thank you very much. That is awesome, because that's exactly what you experienced, right?
100%.
That's exactly what you experienced.
We thought this technology was just going to start, making everybody's lives better right off the bat. And then we realized real quick that what was available at the time was just far too complicated, too complex, and it just wouldn't work.
All right. And somebody's asking for the poll results. And the answer is yes, you can see the poll results. That's the easiest question I've had all day, Rob. All right. So there you go. And if you need to expand that, I think you have to expand it down to make it. I can't share it and make it bigger, but you can drag it and you can see it. Everybody got that? All right. All right. There we go. So stop sharing that. So now that we've already gone through the whole COVID world, right? We now get to be able to see some of the results of that. And JD Power has done a study of that. And look, so there's a lot of good things, right? First of all, people are using it and it went excellently, right? We had a bunch of folks said it went excellent. And then we start to see some of the things that maybe they don't like so much, or you had to do it. And now the question is what's going to motivate people to continue to do it, right? So we do see that patient satisfaction with telehealth has been increasing, but there's several barriers to access, and that puts many patients, especially those most at risk, at not being able to participate. And it goes on to say satisfaction rates are dropping as patients have problems understanding or using it. And this may or may not be similar to my parents and how they operate. So we are up against some challenges.
Right.
Obviously, you have folks, and I don't know if you have the same issue that I have with my parents when it comes to group texts and their ability to manage that. We'll just leave that alone for everybody to digest for about 2 seconds.
Everybody in the audience is shaking their heads right now.
and their ability to manage social media. We can leave that all alone. And it has to do with generations. And I actually participate in some of those generations, but I've learned a little bit from our dialogue from time to time, Rob, that how to do it. So tell us about, let's say, all right, we got folks that are kind of new in this space, got folks that are already here. Let's talk about what that platform and the goals should be for the RPM, which is remote patient monitoring, and telehealth and the virtual care. Tell us about this.
So it kind of goes without saying, the ultimate goal, full stop, is trying to provide a better level of care for our patients. Everything, all else aside, that's what the end goal of this thing really is. And the reality of making that happen, that was just a little bit more challenging. And a good RPM virtual care platform really has to keep in mind, when you're trying to do that, it also can't be a major workload that gets dumped on the physicians or the caregivers. They're not tech experts. They don't want to be tech support. They don't want to spend 2 hours trying to explain to their patients how stuff works, right? And that's, you there, Dave?
Yep, that came in on the front end, actually.
Gotcha.
Yep.
Anyways, so yeah, we're trying to provide this better care, but it's got to be easy to use for both parties, physicians and the patients. And ultimately, on top of all those, in an ideal world, the data that you gather from this stuff needs to flow seamlessly from the devices to the monitors, so that physicians can see it, and then right into their the EMRs. Try to make it as seamless as possible.
And as far as that, now there's a lot of different systems that folks are using. So that back end integration, that was one of the questions. There was a few folks that had some issues with that. I'm sure that it relates to that a little bit.
Yeah, for sure.
Yeah.
Sorry, I got a little bit of a delay in the mic there. Apologies for the glitchiness. Sorry about that. And the other thing that we're trying to take to handle with this whole idea of RPM and telehealth is keeping people out of the hospital, reducing healthcare costs, and keeping people from being readmitted, et cetera. 1 in 5 seniors is readmitted within 30 days. Within 30 days, believe it or not, of a hospital as a general rule. And what we're trying that, and I'm sure everyone in this world knows that readmittances are one of the biggest budget killers for any hospital and medical system that's out there. And it's just, ultimately not what the patient wants to be going through either. Yep. So through our experience, when this stuff is done correctly, it is a tremendous difference how well we're able to keep people out of the hospital.
And that goes also to consistency of the care, and the ability. I think you mentioned that you're going to talk about this in a little bit, but bridging the gap for how often doctors and healthcare practitioners get to be able to interface with clients, with patients too, right?
Yeah, definitely. Yeah. Again,
and the direct access to doctors and nurses, super big.
For sure. And that's, we're trying to come up with a platform that handles all that and makes it streamlined. We've learned a whole lot about this.
And to your point, and somebody was asking the question, I can't remember the name now, of like prepping for surgery. That was a great question, by the way. How can you handle some of the preparatory things? And I would think that a lot of that could be done. And we have a question: are there any situations when not to use telehealth from the net? So do you want to address that for just 1 second? I have a couple that just pop right off the top of my head. You can't do surgery that way, right? But any other pieces that you can think of?
Medical treatment is its own unique animal. Every case is different. For most basics, of course, telehealth can handle that stuff, but there are going to be situations where you just got to be in front of someone. That's kind of a no-brainer, really.
Yep. And those will wind up, and I think you're going to talk about this too, is they're going to wind up revealing themselves as you're having your telehealth interaction, because it doesn't replace things per se. It may be more effective to be able to do it. So
it may prompt you to get someone to go see a physician in person based on what you're seeing through the RPM and through the television.
That's exactly right. So, and we asked the question about the whole telehealth piece, but now we're asking about RPM, which is remote patient monitoring. Remote. That's the short. That's the short. It's remote. What's your experience with remote patient monitoring? Was it physician recommended? Was it patient owned? Was it physician supplied? Was it device provided by an agency or a healthcare system? Was the device monitoring and all included with the professional provided? So all of those could have been provided. And how easy was it for physicians to get the results? They have direct access. Patients had to email. Imagine faxing still do it. And patients had to bring documentation to their visit. So we can see how some of this works, right, Rob? Just by these questions, we can see how some of the pieces are working and flowing within their organizations, right?
Yeah.
Hopefully,
love to see it.
Hopefully, you do it right, like you just mentioned. It's seamless. You see the patient, the doctor gets to be able to see the patient gets to be able to see the doctor or the nurse. Doesn't both, right? It could be either or both, and then they have direct access to be able to help with the escalation, triage, all those things, right? So this was a longer question, so we have to give them a little bit of help with that. But we do know while we're doing that, for remote RPM, right? For remote patient monitoring, the tech is here, right? Everybody and their mother's got one of these things, right? A lot of folks are wearing them, right? We got our Apple Watches that I don't have on because I always forget to charge it. That's just something, that's an internal issue. But we have the connectivity, right? We have broadband at home. We have, a lot of times. Now, rural areas, that's an issue. So that was one of the questions for earlier, right? Connectivity in rural areas is a problem, potentially. But we have monitoring and then access to the medical professionals, as you can see. It's the last time we're going to thank COVID for anything. But without COVID, we could still be the infancy of this, right?
Yeah, definitely. There's no question about it, of course. Yeah. Boom. Absolutely.
Now, we went from infancy to at least teenager in like a month and a half or 2 months. And it was an accelerator. So with that, all right, we're going to give another 5, 4, 3, 2. We got 113. I'm going to go to 115. There it is. All right. So let's take a look at this, because I think this is important. So a lot of times, 28%, about a third of the time, physicians, quarter of the time, recommended the device. 20% is patient owned the device. Love that question. Great question, Rob. That was a good question. Physician supplied device. Not very many. That's interesting. And the device was provided by an agency or healthcare system. So love it. Yeah. Device monitored healthcare. Yeah, 63 and 41%. That's and great. They did all of it. 41% was all inclusive. Love that. And then the physicians had direct access, 72%. That's really cool.
72%. That's really cool.
That's really cool. Really cool. Appreciate that, guys. Great feedback. So within this, though, I think everything that we've learned, and one of the reasons why you're here today, Rob, is that we've understood that there's a need for folks, either seniors, disabled. We had some folks talking about chronic care. You want to talk about that a little bit? So chronic care, you have your temporary post-surgery, that's temporary, right? But then you have your chronic care that you have to monitor essentially forever, right?
Yeah, absolutely. Absolutely. And that's really, I think, ultimately, those are the patients that benefit from it the most, because they are traditionally the ones that have the highest healthcare costs. They need the most visits. They need the most care. And they're not going to get it with the traditional care model. They need to be able to be seen more than once a year, twice a year. Half the patients that we monitor need daily monitoring. I mean, they need someone every day watching what their levels are. And then, hey, Mary, did you go to Dairy Queen last night or something? Your glucose is through the roof today. What happened? Or are your meds not working? Or did you miss it just goes on and on. But chronic care is definitely where you can make the biggest impact.
And that's the biggest cost. You mentioned both, right? So if it's the biggest impact, it's on the cost as well as the patient requiring it, right? And we see a lot with the VA, especially when you have PTSD, mentally, you have a whole bunch of mental issues now that we continue to become aware of, right? And this gives you the ability to make sure that folks are doing okay. You know,
Right.
it's a check-in, and you're monitoring it, and you can start to see some of those physiological changes, right?
Sure.
And then obviously socioeconomic and rural communities important to be able to bridge the gap, because you just can't drive. Literally, my father-in-law yesterday drove an hour and a half to Bowling Green and stayed overnight because they had multiple visits. And then he may or may not have driven home before this one of the visits because
he was just over it.
Whatever, what are you going to do? What are you going to do? Right. And technologically challenged, we'll leave that alone because we all fall into that category sometimes. So the approach here that you're talking about is being turnkey. So what does that mean to be turnkey?
That means that, the doctor can basically either give them a physical box or call a company like us and basically write a prescription for what they need. And we get them engaged and they get a box that shows up that is ready to go. They don't have to pair it to their phone. They don't have to try to set up Wi-Fi. They don't have to figure out how these different things works. They get a turnkey solution that they get it. There's a very basic, simple instruction. You put it on and the results start going to the appropriate doctor.
And obviously it has to be HIPAA compliant because we're talking about healthcare data, right?
Right, of course. And then on the backside for this goes back to what we were talking about earlier. On the backside of that, the doctors can't be overwhelmed either. The caregivers, right. That's got to be something that they're not, okay, I got to go do my visits and get the readings. And then I got to take all my case notes and I have to manually put them into the EMR. And now that because they're doing more visits, there's more paperwork. That has to be streamlined so that they're not getting overwhelmed.
Wow. I didn't even think about that. So if you wind up touching the patient more, you automatically have an increase in your paperwork.
Mm-hmm.
Didn't even think about that. And I love what you said about this is that no matter we'll talk about what you do in just a minute, but the onus of the technological components, you don't want to saddle it even in your agency, right? You do have some connectivity in your agency. You're going to have to go to your CIO and the people that are operating in your IT to make sure everything is secure, all those pieces, all that has to still happen. Yet you can still, as federal contracts are doing, driving that work over to the vendors, right?
Absolutely.
Yep. And to your point, minimizing the workload on your staff, and the lift that they have to do. And ultimately, the patient records, we've been doing digitization for the past, 15, 18 years to digitize the records. Now we have the ability to provide those patient records and transcripts virtually immediately, right?
Virtually, yep.
That's the idea. So if you're gonna make the jump, if you're gonna make the leap into something that is end to end, and that you can offload what you don't do every day.
Sure.
Right? What these people don't do every day is figure out how the freaking app works on this freaking phone, right? You don't have, that's not what you want the patient to do. And that's not what you want your physicians to be doing either. I guarantee you.
My personal physician actually had me about 6 months ago do a FaceTime on Facebook.
Facebook?
Whatever the Facebook video app is, I don't remember what it's called, but that was his telehealth. And it was like, really? Okay.
Really?
It's pretty crazy.
There's a whole lot of this word right here. Let me see if I can draw something. This word right here, the HIPAA, has to be addressed from that. We'll deal with that another time. That is your own issue to deal with your provider. We're not going to be talking about that here. But let's talk about what you do. So you have, for very briefly, you have this, it's HIPAA compliant. It is streamlined to integrate with EMR. EMR is what?
Your electronic medical record.
Okay, there you go. So the abbreviations that everybody else here knew that I didn't. All right. So it transcribes your visits. A big
Yeah.
important piece
On
is
the,
that,
on the telehealth side, when you're doing a virtual visit, on our platform at least, both sides of the conversation of the doctor and the patient are transcribed and recorded. And then that can get dumped off into a form that can be uploaded again into the EMR.
right on.
They don't even have to go back through and take all the notes. You know, they're going to take notes anyways, but you know, it just streamlines the amount of paperwork that they have to do.
That is remarkable. I love it. And one of the components that you have is it's cellular based, right?
And that goes back to that's two different reasons. The why we went down that path in the beginning was because we were initially dealing with a group of seniors, and they didn't know what Wi-Fi meant, where the Wi-Fi came from, what the password was. You know, they'd have to call their grandson over to come, and I hate to be stereotypical like that, but that's literally what was happening, where someone would have to come over, and when we first went down this path, and they'd have to get them all up and running, and that was completely the opposite of what we were trying to accomplish.
Yeah.
Right?
Well, first of all, stop talking about me and my parents.
Right.
Stop.
But your parents would look like an easy target there. But no, so the cellular base took care of at least that major component. And, you know, there are areas where they still don't have Wi-Fi. But so, and to put it on the flip side, there are also areas I realize that, you know, some places don't have cell service. You know, there's kind of both angles there. So our system comes by default set up for cellular, but it can be switched over to Wi-Fi, and we can do that remotely if we need to do such a thing.
Fantastic. And one of the biggest things I think that folks are, and I'm going to get to some questions because there's some questions. I think people putting stuff in chat. If you put a question in the chat, I probably won't be able to see it. But if you pop what you put in the chat into the Q&A, I promise you I'll be able to see that one. I'm going to review the chat too, see if I can. But do that for me if you can. But the other part is, if you see something, right, that comes through the monitoring that the patient may not even be aware of, the case managers in this instance, who's the case manager from your perspective? What does that mean?
So we have two different models. So we have the model where we just basically send these systems out, and the primary care physician can use our platform to monitor their patients. And then the other model is the physician doesn't want to deal with any of that. They just want someone else to be monitoring their patients, in which case we have a medical director and nurses and staff that do the actual monitoring. And they'll do the virtual visits and, you know, kind of stay on top of the routine stuff. If there is an issue that comes up, they can escalate and make a direct contact with the primary care physician, set up an appointment, kind of go down that path. So
whoever that is on the case management side, defined by the internal structure of whatever the agency, the organization, the practice, whatever it happens to be, they make the decision. The case manager can wake up, call the device and say, hey, Dave.
So that goes back to, you know, best practices are, we try to set up an appointment ahead of time, a virtual visit. You know, we set up an appointment, Mary, be on at 2 p.m. on Wednesday afternoon for your virtual visit type of thing. Very often those would get missed. So we basically came up with this. Well, we can now, our caregivers, our case managers can actually wake up and call the device. So if the patient forgets to make the call, the doctor can initiate the call and say, hey, where are you? I don't want to miss this window. And likewise, if they're going through and monitoring and they see a level that's just out of whack, depending on what it is that they're looking at, you know, they can, of course, initiate a call to check in with the patient real quick.
And so, first of all, stop talking about me forgetting my meetings and stuff and all my appointments. That's, again, this is way too personal. But at the end of the day, everything that we talked about, you talked about it before, offloading it to the vendor. You, in this instance, are the vendor, right? And you take care of all the hardware, software, tech support, and you can talk about ancillary services too. But sure, all the functionality and the pieces that enable the connectivity as well as the monitoring are handled by you, right? Right.
Yep. And if they go down that path, and even if we are the ones doing the monitoring, there's many different levels and different ways we could do that, but at a minimum, once a week, they'll get a report out on all of their patients' weekly activities.
Right on.
Or we can do less. And so they stay engaged with their primary care physician, even though we're the ones doing the monitoring.
Got it. So the reason why we had to set that up is because a lot of folks aren't aware of the different even what is possible. So we set that up because you use this platform with a particular case study, and you did 100 senior patients in a clinical trial. And this is really important for everybody that's running telehealth to understand what the implications are here. And there was a question about of when it can be better or not, as good as in inpatient, but you have some remarkable things to share here. So first things first, all the active medical interaction with all the patients. So every one of these patients participated in this 100%, right?
Yep. And that came down to, again, we have an in-home senior care company, and we just onboarded, we went around to some of them and wanted to introduce the technology, and we picked 100 of them, or we let them opt in. We didn't pick them. We wanted to keep it as neutral as possible. But anyways, we got 100 of them signed up. And what we found was staggering. And I'm just going to jump right to the exciting part for me, because every time I think about it, the hair on the back of my arm stands up. In just 100 patients that we picked, now granted they were seniors, but in just 100 patients that we picked, we identified 7 of them that had AFib, that had no idea.
Wait a minute. You had 7 patients that had AFib that wasn't even in their regular medical records?
Correct. They were just normal seniors that were going about, again, they'd have their yearly or their twice a year doctor visit and didn't get identified because it wasn't acting up when they were there, a multitude of different reasons. But I mean, we have video testimonials, if I could share that, at a later date, if somebody wants to see that, of these people going, I think they saved my life. I mean, it was powerful stuff.
That does. And only because it happened this way.
We had a nurse practitioner that was just reading their vitals every day. And then on 7 different occasions, the nurse practitioner was like, whoa, something's not right here. And then they escalated it, had them go into their primary care physician and found out, yeah, they had AFib. And
that gave the ability to order the emergency medical treatment and have them go in. And this,
fortunately, it kept them out of being in the ER, right? That's kind of the idea. We prevented the heart attack from happening, prevented the emergency care by, at least when we identified it before, and they didn't have to wait 9 months till their next doctor's appointment, where it would have just gotten worse or been unmanaged.
Right. And I think this goes to, obviously, that's like, I love those. That's an incredible story. So you have AFib patient, but you also have your chronic care, and you mentioned diabetes before. Did you go to Dairy Queen? Stop talking about me again. But being able to get that information in and apply it appropriately, right? So at the end of the day, you have 7% of those, 7% of those patients are saying, hey, this saved my life.
Yeah, and the other nice thing that it did, and it was this was just something that you had to kind of see it, I guess, as they say, but the patients felt better about the level of care they were getting. All of a sudden, I mean, they just felt like they were getting the best health care in the world, because there is someone walking them through and they know that someone's looking at their pulse and their blood ox and their glucose and, all these things on a much more regular schedule. And then our nurse would reach out, once a week or once a month, depending on the case, and get more involved with them.
Well, you got it right here too, right? Look at this, monthly minimum.
Yeah.
And often weekly. How often? A lot of times, if they were coming from a once or twice a year to now running monthly,
right,
or weekly. I think that's right. So at the end of the day, what I love about you is lives saved. Just boom, lives saved. 2 things here. You had the ability, if you needed to, call emergency personnel, have them show up at the doorstep, right? You had the ability to do that. And more importantly, non-emergency treatment, all the rest of the 93 that weren't life, critical, all those things could be handled remotely. They didn't have to come in for a visit. And to your point, they felt better because they felt they had better care.
Absolutely.
There's so much common sense here. It
really is.
It really is common sense. So, and then what I love about what you said here with this case study is it reinforced the need for turnkey accessibility. It didn't start out that way, did it?
No, again, the whole dealing with seniors, when we started initially, and we'd tell them they had to pair it to their phone and then email us the reports. And, the turnkey is what made this thing really work. And we finally boxed it up, prepared. We had a literal box. They opened it up and they got up in the morning. The only thing we would have to do is basically say, okay, let's try to get this into your morning routine. And let's just use blood pressure because it's the easy one. So you wake up in the morning, you have the device by your bed, you check, just like you do every morning. You get up before you have your cup of coffee, take your blood pressure. And in our system, you put the band on, hit the green button, let it do its thing, put it back in the box and go about your day. Takes 15 seconds as soon as they wake up out of bed, that kind of thing. But then they get in the routine of doing it over and over. It becomes habit. And that's where you start to get the benefits of really getting the data and really see what's going on, because you're getting it every single day. And the other beauty about the thing being cellular based is even if they go on vacation, go to visit the kids at Christmas, or get moved into from being on their own, going into some kind of a care facility, they can still we don't even miss a day of readings because it's all remote.
Yeah, fantastic. And one of the pieces that you talked about before is impacting the mental health. And because you're doing this every day and it becomes a routine, you find out if they miss a day, right?
Sure.
If they're missing, if they have physiological symptoms, if that's an indicator of whether medication is being taken or not,
right,
or if their stress levels are exceptionally high. All of those things are all part of that, right?
Absolutely. Yeah.
And the most important thing that I've heard, and I've been involved with different studies with the VA. We've talked about surveying and finding out when a veteran is at risk for suicide. The being able to get that person to a health professional as quickly as possible is really what saves lives.
And it kind of goes a step further than that, because doing it like this, they don't have to leave their home and go visit a doctor somewhere.
Yeah. Or make a phone call.
Or even, this is quite literally, if they're already in the system, we just hit the button and we can call them and touch them every day. Or, if they're having some bad thoughts, hopefully all they have to do is pick it up and hit the green button and get in touch with, their medical professional. And it just trying to make that, asking for help in that situation is often the most challenging part of dealing with it.
Mm-hmm.
And as much as you can do to make that process easier and simpler, that you win that much more.
Love it. All right. So there's folks that actually selected pilot, right? So you can pilot a turnkey healthcare telehealth process. All it takes is choosing the patients. It gives you the ability to measure the usage, prove the effectiveness, and discover the potential. Because what will happen is once you do it, you start to say, I could use it for that. I could use it for this. And that can happen. And oftentimes this happens under simplified acquisition. This is stuff that Rob doesn't understand as much of, but the idea of simplified acquisition, and also can be done by provider or administrator. We have both sides in this, right? We talked about that the coverage of that is probably 75% of the people that are here today. So provider initiated, administrator led, and then these can be operational within 30 days. Sometimes in your instance, it can be operational quicker than that. But if it's 100, you can do it within a couple of days, right?
Absolutely.
And then if it's 10,000, you're going to need a few days to pull that together, right?
Yep. I'm sorry. I was reading the comments at the bottom there. Yes, absolutely. If we're going to go through a big order or something like that, then definitely.
That's right.
But again, we're not looking at 6 months. We're looking at 30 days, 45 days, something like that.
Yeah. And for huge, right? So, but the most important thing is and whether or not you're asking for Commandant MD to do it, this is the process to use. Use it as a pilot, figure out how it works within your organization, and then go about doing it. All right. So if you want to continue the conversation, here's how we're going to do it. If you'd like, we need help with meeting telehealth initiatives. You have a pilot you want to discuss with Comment. You'd like to schedule a demo with Comment. I'd like to be a panelist. We have a bunch of folks that asked to be panelists or hosts for the next telehealth briefing. If that's you, fill that out, or something else, please contact me. And when do you want the help? And we'll make sure we get that to you. We'll leave that open for a little bit. We have some questions. From Renee, we will start handling remote monitoring of pacemaker and implantable loop recording. Do you think the insurance companies will continue to allow virtual visits? From Renee. Great question. What do you think about that?
Yeah, absolutely. So, as we know, they opened it all up because of COVID. And then there was talk that they were going to start clamping down on it. And what we have found is what they basically said is, okay, this whole idea of telehealth is working. So we want to make that available, but no more using Facebook, no more using, the cheapest, most unsecure platform that's out there. Everything's going to have to be HIPAA compliant moving forward.
Got it. Love it. Hunter says chronic disease management is crucial and telehealth can and been proven to help. Absolutely. However, does psychiatric care play into this? Is this something that is already being successfully implemented? Great question, Hunter.
Yeah, we have several practices that we deal with, of course, and it kind of goes back to something you said a moment ago. They started using it just for doing, I believe the case that I'm thinking of, doing glucose and blood pressure. They wanted to dealt with a lot of that. And after about 4 months of using it, they had a mental health specialist that walked by and literally saw them doing a visit and was like, wow, can I do that? We have that? How do I get that for my patients now? And it just kind of snowballed, and all of their departments now use one form or the other of it.
And that's exactly what we're talking about.
Yeah, I kind of went on a spiral there, but yes.
No,
so mental health, especially doing evaluations, where you just, and the routine checking in on someone, make sure they're taking their meds. You can see the physiological effects with the RPM and get in front of them before it becomes an issue.
All right. And Brenda's saying, we've done this at our VA. Fantastic. It's working well. Love it. We had to do this during COVID. Absolutely. Love that. Renee says, with this device, does this eliminate the need for nurses who currently do the RPM? And you can answer that. I have a question or a follow-on question. But
no, I mean, it's just a tool so the nurses can use the RPM and make it more. We'd like to think it's, I don't know what, she's using in particular, but we like to think that it's more streamlined the way that we do it.
And your lane, so everybody knows. I mean, there's people that are always going to be defaulting to apps that run on iPhones and other things that are tech savvy, that want to use their own watches, that want to use their own, whatever it happens to be, right? So because that was one of the questions. But at the end of the day, you're talking about your lane that you do is the senior care, disabled, folks that have trouble with some of the technology, either
absolutely,
from a standpoint of generationally being, generationally challenged. We said it before. Yes, my grandson too can do this better than me, and that's the way that it is for us, right? So yeah, I think that's a great concern, Renee, because I think it's an enhancer for what's happening. And one of the things that you can talk about too is some of the overflow that you do for folks to be able to help with that. Because there's sometimes they can't, maybe they're overloaded, right?
Yeah. So again, and a lot of the times the nurses that are doing some of this RPM are doing the type of care where they'll go once a month to the patient's home. There's still a need to have that, that touch, that once a month touch, but now they can get that once a month touch, but every day they get a report on how their patient's doing. So, sometimes waiting 30 days is just too long. Mm-hmm. Just gets them the information more quickly. And then,
Brent, sorry, go ahead.
What you were talking about before, a part of what we do, there's kind of two different models that we do ourselves. And again, to kind of recap, we have this whole system that we can kind of implement or have practices implement on their own. And then we have other practices that just have more patients than they can handle. And they want this data, they want this information, but they can't physically do it all on their own to handle that workload. So in that scenario, we do all the monitoring. We send out the hardware, we do the monitoring. And we're in touch often with the nurses that are out in the fields every day. Mm-hmm. We've got a different medical people that we deal with internally that are have on a first name basis with some of the nurses at some of the other practices that we deal with, because they get them and they call them and say, hey, I know that so-and-so is your patient. I just want to let you know, her glucose is spiking awful the past couple of days. You might want to, step up your next visit.
Mhm. And Brenda was talking about the psychiatric care is what she was talking about. They have a lot of remote care going on. So yes, psychiatric care is part of that. I think it's probably one of the biggest growth areas you could possibly have.
Absolutely.
All right. So Renee's asking, how is AFib detected, Mr. Technical Guy?
I'm not the doctor or the caregiver. I'm not the
All right,
one who was, I'd have to defer to my doctor or nurse, but it works for us, but I can find out.
That's right. So Renee wants to know. And Margot says, is there a Spanish language version or support staff?
Not as of yet, but it's definitely in development.
There we go. Fantastic. I'm going to go to the chats because I know people are doing chat stuff. Let's see. Is Common MD a competitor of VA Video Connect? I don't know what that is, Janice, but if I would say that it's probably not a competitor, it's probably going to be an augmentor. And think about this, right? So the VA has their core and you have all your facilities, and you already know that you've done some outsourcing because you can't do the coverage. You have smaller clinics that have been outsourced to. You have outsourced to other folks, all of those things. I don't think it's either or. I think it's a both. And you are welcome, Latamika. Love that name. Yes, Michelle, for those of you who joined late, real quick, actually, I'll talk about that in a minute. For those of you who joined late, have you looked at a more concerted program to assist at hospital at home programs or better post-discharge education monitoring? Very great, Susan Wu. Great question. And the answer is, I think that this applies.
It applies, and we actually have, there's lots of different things to talk about, but we actually have a program that we have set up for dealing with all discharges to keep them from becoming readmittances that we have implemented.
So Anita's saying, one of my concerns has to do with metrics and accurate representation of the value of virtual care. I'm a specialist, and oftentimes my initial consultation with the patient results in a second appointment for an office-based procedure. Certainly. I'm concerned that one of the metrics of effectiveness of virtual care that I've seen is whether the virtual care visit results in a short-term face-to-face appointment. The data is nuanced enough to realize that the second appointment would have been scheduled regularly. You're right. We're not in maturity model, right? Yet, Rob? So her whole thing is the metrics and accurate representation, because what's going to happen is it's going to be driven either by insurance companies or by agencies, right? To say, look, you're going to do X amount of virtual care, and it goes to the management of your virtual care model, right? And there will be nuances that are going to affect agencies differently.
Yeah, sure. There's also standard PCP codes, if they're talking about billing in particular, where everyone, you can bill for a training session, and then you can bill for the initial visit and then a recurring visit. So all those things are kind of there's already a program for the insurance companies to get reimbursed, to reimburse for that specific different things. Right on. We actually, again, it boils in, when you set the appointments and all that, definitely comes down to what your business is, or what your physician's model is, if you will. But all the people that we do chronic care monitoring of, as I said before, at least a minimum, we get the readings every day, and the minimum is a once a month touch from a nurse, virtual touch. Most of them are at least once a week virtual touch, and often that leads into a follow-up appointment a few days later or a referral to their PCP.
Right. Real quick, there's some people that have to go, so we're going to let them out. Yep. If I mentioned earlier, there's no obligation to purchase from any vendor. If you'd like to talk to Common MD, their information is here. You're working, everybody here, if I could just make this plea. If you know somebody that Rob needs to talk to because you're in the VA and they're veteran owned or service disabled veteran owned, that it has to go through them first because of the Vet First program. Please do an introduction. Say, hey, talk to these guys. It's not an endorsement to say that that any partnership should be formed, but let him know the good guys, because he needs to know who the good guys are, right? And it goes with Hub Zone 8A, women-owned, GSA schedule holders. That's all I'm asking from folks. For the folks that join late, you will get a recap by the end of the day. You have the briefing presentation, which will have links to the docs, the video, and a one-on-one meeting with Rob and his team, or somebody on his team. And as Rob said, he's not the doctor. He doesn't even play one on TV. So he will pull in the type of people that you need to talk to. And I'm going to pop this up to say thanks for joining us. We got a couple of questions we're going to answer, but here's the contact information. Again, if you'd like to be part of the next one, is we're going to be doing another one. This one was so many people signed up for this. We saw that it was a super hot topic for you. If you want to participate, if you want to be one of the host panelists, whatever it is, let me know. We'll make sure you get incorporated in that. And there's no charge to the Govies to be part of that. So let's go back to AFib from VHA Mary D. I think that's it. AFib is difficult to get oxygen saturation, irregular heart rate, HX, CHF, COPD, sleep apnea, all those things, right?
Yep.
Regardless of whether the initial consult was face-to-face or virtual, comes from Anita. I think that goes to what we were talking about. Yeah. That goes, and I think Anita's question was originally the one, let me go back, about the concerns about the metrics, right? There is no silver bullet in anything medical, right, Rob?
There is no.
We just develop tools.
Absolutely.
Right? And we get better at developing the tools, and then management has to get better at the metrics too. There's no panacea here, right?
However, I'm not sure what the question is really driving at there, but if it has something to do with, how accurate is the actual equipment that we're using? Yeah, we have all the data to back up this, statistically, the margin of error and all that stuff, and it's minuscule.
I think her question was more along, okay, how do the metrics and accurate representation of the value of virtual care? So she's going to the metrics of the value. And your clinical study, or your study that you did with your 100, right, is an indicator of the value. It's not built to make it drive the metrics down through any organization, because I think as organizations use this, the metrics are going to have to be understood internally, developed and understood internally.
Yes, I can speak to this. I can't go into details, because we've got confidentiality agreements and all that stuff. But we are in talks with one of the largest insurance providers out there right now. And they're setting up a pilot program that they want to get us monitoring their highest risk, most expensive patients. Because it's so relatively inexpensive, the cost of doing this, but it saves so much money to the insurance provider if we can stop these different instances of people going to the ER, going to the hospital. Yeah. And they've done the math on it, and it's staggering what the projected savings are.
Yeah. And again, improvements will be made.
Yep.
Right. So what about veterans with COPD, HF? Does this device allow the veteran to weigh themselves? Does the device ask health questions related to the chronic illness the patients have? Great question, Renee Williams. Awesome.
We have, this device is actually a suite of devices, all based on a cellular tablet. We really didn't get into too much specifics of what CommonMD does, but that tablet comes connected with several different devices based on what the caregiver wants to monitor, right? And yeah, we can do pulse ox, glucose, of course, blood pressure, weight, body mass. There's a litany of devices that we can gather data on.
Yeah. And it's only going to get better with AI and all the rest of things that are coming down the pipe. This is the functionality to gather the information as well, right? And Anita saying, I'm looking more at how the administrators look at this with regard to the pilot programs. I agree. Yeah, and those metrics. And she also says in the chat, I'm interested in meeting with you about opportunities with your company. She's a physician. So there you go. I am certain that that Rob will want to do that. Jeez Louise, I already hit the button. Sorry about that. Renee says, thank you. You are welcome, Renee. All right, guys. Well, we're a little bit over, all because of the topic being so hot. We will be doing this again. You will get some additional information at the end of the day, as I mentioned, and continue the conversation with Rob. A lot of the things, like Anita, like you said, hey, just talk about it. See what there is, and look at your options. You know, Rob has his. There's other options out there.
And I guarantee I'll learn some stuff from you folks.
Yeah, absolutely. And that's the big deal, is that this is a dialogue. It's not meant to be a one-way conversation. It's meant to be a dialogue. How can things be improved? And I can tell you from the GovBrief side, that's what we love the most. We love to be able to have the dialogue and say, this is what we see. Here's some new technology. Here's some of the best practices, because that's what the most important thing for you to know. What is happening right now in order to reach a particular lane? Rob's lane, very specific: senior, disabled, folks that have trouble with technology. That's your lane, right, Rob?
Absolutely.
Fantastic. Well, great stuff. Appreciate everything. Great stories. The 7% life saving, that is remarkable.
Yep.
That alone was
so that little study is what made me go, you know what, we're doing this. We're going to make this better, and we're going to do it.
Yep. All right, fantastic, guys. And if I miss anything in the chat, we're going to make sure that Rob gets the chat. Otherwise, we'll get you out of here. Thanks for joining us, and great job, Rob.
I got you, Dave. Appreciate you.
Thanks. See you guys.